Good evening, everyone. On behalf of Intas Pharmaceutical Limited, welcome you all to this third episode of webinar series, Endocrine Talk Show. And today we are going to discuss one of the important aspects in day-to-day practice, that is the addressing the fertility. And we have galaxy of experts who are going to dissect this topic in depth, and they are going to guide us in a various aspect in managing fertility. And to guide us today and moderate this session, we are having with us our course director for the program, Dr. Subhankar Chaudhary sir. He is a professor and head at Department of Endocrinology, SSKM Hospital, Kolkata. He is also former editor-in-chief for the Indian Journal of Endocrinology and Metabolism, past president for Endocrine Society of India, and he has multiple publications to his credit in various national and international journals. So with this word, I hand over this digital podium to Dr. Chaudhary sir. Over to you, sir.
Thank you very much. A warm welcome to all of our friends from across the country. I hope this program over the months and approaching 2 years has been of some use. It started during the dark days of the first lockdown, and it is continued, mainly because of the enthusiasm shown by our physician community. And this evening, we are happy to be graced by a number of faculty members, not only from the discipline of endocrinology, but considering this evening's topic being infertility, we have also got amongst us a gynecologist. So let me quickly introduce the members who are, of course, known far and wide. We have Dr. Usha Sriram. I hope Usha has joined, who is sort of a queen of endocrinology. And physically, of course, she is in Chennai, but she's all across. And she is very passionate about non-communicable diseases affecting girls and women. And she's actually the founder of an NGO, DIWAS. And of course, at this point of time, she is president of the ISPA, Indian Society for Bone Mineral Research. She's an idea stream for women and diabetes committee, and she's got so many other things. And she's a wonderful speaker, an excellent person, a very good friend. Welcome, Usha. Unfortunately, we will not be able to hear the pearls from Dr. Vagish Iyer, who is from Bangalore, St. John's Medical College. Because of a medical emergency, he has had to go to attend hospital with someone else. But we have with us two more eminent endocrinologists, Dr. Joe George, who is a senior consultant endocrinology from Endocrine Group, and he's a director of Endocrine Group of institutions. And he has had numerous, once again, feathers to his cap. And he's been a wonderful host, organizing very good meetings in Kerala. He was a former secretary of the Malabar Endocrine Society and organizing secretary of MENDOS in 2015 and 2016. And he is great speaker. And we have from Kolkata, Professor Devman Rosanyani, who is a professor of endocrinology at the KPC Medical College, is a senior consultant endocrinologist attached to all the most important private hospitals in the city, including the Narayana Group of Hospitals, GD Diabetes Institute, AMRI Hospital, and so on. He has got numerous publications to his name. And we are, as I have already indicated, delighted and especially happy to have with us Dr. Ratnamali Chakraborty, who is director of IVF Infertility Center. He's consultant in, again, different important hospitals in the city, the Manipal Hospital, Institute of Laparoscopic Surgery, Bhagirathi Niyoti of Women and Child Care Center, and so on. And he has got a rich experience of several decades, and he was not too long back was president of the Menopausal Society of India. So we have this rich faculty, so make the best use of all of them. So I request all of the participants to put in your questions the way that you do, put it in the chat box, and we shall try and take as many as possible. So straight off, infertility is an issue that we see, of course, in many patients coming to us. But in our country, with a billion plus people, what's the current figure? More than 1.3 billion, is it? Or something like that. Is infertility, I mean, how is infertility looked at? For example, Usha, because you are amongst the senior most, if you were a public health official, would you be interested in investing in evaluation treatment of infertility? Because we have too many people already.
Thank you, Shivankar, and thank you for those very nice words you said about me. Thank you so much. And always a pleasure to be part of this program. So this is a very important question because yes, it is true that we have 1.3 billion plus people and only on the rise, but at the same time, we have this huge number of people. It is said that anywhere from, I think recently All India Institute of Medical Sciences said anywhere from 10 to 15% of couples go through fertility issues. So that's a large number. And for that individual couple, of course, this is a very, very important issue. And also, if you go back to the root cause of what is causing this rise in infertility, so that has really major public health implications. And as both as an endocrinologist and even if you said as a member of the community, I'm seriously interested in why this is happening. Okay, so
right, yeah.
Why this is happening? Sorry, just one more sentence.
Yes,
why
yes,
this is happening is of great significance because we have lifestyle issues that are happening like obesity and nutritional issues that are contributing to this. Then there are environmental factors like pollution and endocrine disruptors that are contributing to this. And then problems like PCOS that's on the rise, that's contributing to this as well. And then a whole slew of other medical and endocrine conditions, including diabetes, that is on the rise. And all of these are contributing in a big way to this rise in to this big number that we are seeing. So it is a very, very, very important issue. I do not think we should look at it as we already have a lot of people. Why should we worry about infertility? Because yes, we have a lot of people and it's only going to go up, but we also have this very big problem. And I am definitely concerned about why this is so, and investigate it properly and offer the right solutions to the couple who are going through this.
Absolutely. And traditionally, infertility has been the domain of the gynecologists, traditionally. And this is a question to Dr. Ratnavali Chakraborty. If you look across the teaching hospitals, the government teaching hospitals, which have been the traditional teaching hospitals, now, of course, we have so many private teaching hospitals, we do not have dedicated infertility treatment facilities yet. Maybe All India Institute has opened in our city, in my institute, IPJMR, there has been a talk, there has been discussions, and in principle, it has been accepted to start a full-fledged proper infertility treatment center along with facilities for IVF. So why is it that government institutes have not yet come up in a big way.
So, thank you, Shivankar, for your kind introduction and the question. Very interesting question. Can you hear me properly?
Yes,
Yeah.
absolutely.
So, when we are studying infertility, or we are, facing an infertility patient, it seems that it is very easy to tackle them. But once you start doing the treatment, you will find that it is a totally, time consuming, your energy consuming, as well as your expertise consuming subject. So unless you dedicate yourself totally into it, for example, oncosurgeon of a specific doing only commando operations, that will give you the best result. Otherwise, you're doing it and something, okay, I have to do it and I'm doing it. So in the government medical colleges, even if you open it, there are 3 tiers of treatment in infertility. The tier 1, which usually all gynecologists do, treating the PCOS or maybe timing the course and stuff like that. The second tier is where you do IUI. That can also be done in a setup where you may not dedicate the whole of your time. But once you go to the final tier where you have to do IVF, you're doing ICSI, you are doing blastocyst cultures, you are doing cryopreservation, maintaining semen banks, it is impossible for a general person who is doing gynecology or obstetrics to maintain the wholeheartedly that you won't get the result. You have to compare. Nowadays everybody goes to the Google and knows what is the fertility, what is the pregnancy rate after first cycle. So if you don't give that result, that won't happen. So when you think about in the medical college, you know the patients who usually come there in a department of gynae and obs with all sorts of cancers, rupture uterus, ectopies, very difficult cases of obstetrics. It's not expected that unless there is a dedicated team, they can continue it with it. Now, government of West Bengal have thought about it. You know better than me that they are now establishing centers here and there, and maybe they will train up people, make some groups so that also the poor people of Indian population can get the help of the recent technologies of IVF, etc.
Yes, I mean, this is of course not a forum where we have gynecologists in large numbers, but I think would it not help? Maybe a short answer will be all that we are looking for. If in the field of gynecology and obstetrics, we did have more super specialty departments coming up. Medicine has now become cardiology, neurology, gastroenterology, so on and so forth. Surgery has also developed somewhat, but still it is a huge area. Gynecology and obstetrics, still it remains a single department. I think if people took upon themselves and developed individual sub or super specialties, maybe we would have maybe DM courses or MS courses in infertility within gynecology. Some would be maybe oncosurgery, gynecological oncosurgery. I don't know. That may be a way forward is what I see.
No, what you say is absolutely true. Unless and otherwise you give importance to the subject. Till date, it was the subject that you deliver. So it's nothing to do with a very intelligent process. Then came a bit of endocrinology in the gynecology, some part of it laparoscopy. So you're a bit of a surgeon, you're a bit of an endocrinologist, you're a bit of an oncologist, so and so on and so forth. Then nowadays, people are really once they are into gynecology, they're trying to find out which way they will be going. Infertility, okay, fine. Then it has become a super specialty. Oncosurgery in gynecology, it has become a super specialty like that. So in near future, I think it will take another 15 years. Then you will find absolutely divided, and they are making much better result, much more dedicated field of team working in the field.
Right. Yeah, absolutely. So we come to Dr. Demalo Sannand. Now, we as endocrinologists talk of, and just now Usha did mention about diabetes being on the rise. So everything is on the rise, we feel. So what about infertility? Is that also on the rise?
Thank you, sir, for the kind introduction. And again, if we see the overall last few decades comparison with regards to the prevalence of infertility, there has been a significant increase in infertility. And especially if we look at it, as we have seen, the current projection is about 10 to 15% of all couples have infertility. And unfortunately, in developing countries like ours also, there has been a significant increase in infertility as well. If we look at it from our country's perspective, apart from other agents, other diseases which we have talked about, infectious disease also remains an important contributor to infertility as well, still now. So that is still an important contributor. And even over the last few decades, if we even look at the World Health Organization cutoffs for different semen analysis as well, that has gone down. And if we look at the overall semen count, and then if we can see, there's been a significant decrease in that. And both in men and in women, there's been a significant increase in infertility. This may be because of environmental toxins. Endocrine disruptors may be a very important cause because of that as well. And also because of substance abuse, something which was not so very common in our country, which we see also more in our country as well. Use of anabolic steroids in men also has significantly improved from in different spheres. So it's all environment, toxins, and even if we see the industrialization and the average rise in temperature in people working in different sectors, that also has significantly increased the contribution of infertility. So there are numerous causes, but overall, the fertility, even in young people, have decreased significantly, and the infertility rates are rising significantly. So that is a matter of concern as well. And in spite of the fact that our population is growing, it is projected by this end of this century or middle of this century, it is going to stabilize. And actually, we are going to have a decrease in our population by the end of it, which is actually going to have which is going to put us at an increased disadvantage, because we are going to have a significant amount of elderly population to support. That is also an important financial aspect as well.
Right. So the clear message is fertility is also increasing. And I think on top of all these, something you talked about industrial toxins, environmental toxins, whatever. I think, what about the social toxin, the stress? Is that not also a likely contributor? Anyone? I mean, a general, this is of course not very specific. What do you think? Bigmallo?
Yes, sir, and even the social, especially even which we see nowadays is when we ask even in our patients, especially with regards to their regularity of their sexual lives as well, that has been even during this period of our COVID period, there has been significant improvement, even being confined to say. But what has importantly hampered is that, that because of stress and also global travel, also the chances of, the fertility has taken, and also having children has taken a backseat in today's world. And also because of the stress, there is less chances of any interactions have also come down. So these are very important aspects to consider as well.
There was a study report, if I can add, where it was shown why the couples are now postponing their pregnancy and ultimately are a victim of infertility. So it has been shown that to have my own home, 48% gave a reason for that. I'm waiting to have my own home. There was 19% told I must have my own car. Then to finish my study, postgraduate and whatever, that was in 23%. To have my next promotion, that came up in almost 17%. And the other one, the most important, to settle in a place where I can have my proper medical facility. Maybe they are working in Sundarban. So that came up in 7%. And ultimately came the most important. We are trying to find out whether my, the spouse, I have a permanent relationship with the spouse so that he will be my son's father, or the other person is thinking whether we can have a permanent relationship to have, son or daughter so that she can be the mother. So even there is a controversy in that they are scared whether this relationship will continue or not. So this came up in a statistics which was done some 4 years back, and this is what is the situation now.
Right. So there are so many layers to infertility, and so Dr. Demallo did mention also that there may be a deterioration in sperm quality over a period of time. Joe, what are your thoughts on that? Implications? Would that be the main reason for maybe increasing infertility that we see now? And
Yes,
what would be the causes?
Yeah, thank you, sir, for the initial introduction and the question. So from the early 90s, there was a meta-analysis which initially showed that there is a gradual decline in the sperm quantity and quality over the last 50 to 70 years, which has been criticized a lot by major experts. But further down, there have been repeated meta-analysis where these problems with the initial meta-analysis studies were tried to be corrected. But still, all those meta-analysis actually pointed towards only one fact, that there is a definite decline in the sperm quantity and quality over the decades, internationally, all over the world. But only thing is that there have been geographic variations. There have been variations that has been seen between urban and rural. And also a lot of bias can come into these analysis, because when you analyze sperm, to get a random sample is very difficult. So there is a lot of bias that come, because a person who is willing to give the semen for analysis itself would have some motive behind that, or some interest or some level of commitment towards that. So there is a lot of bias that come into these kind of studies. So the analysis can be flawed a lot. So a lot of bias can come into it. So if you look from the Indian studies also, there was one study in 2008 from Adiga et al., which looked upon the sperm quality and analysis of a 13 years period, which again showed the same results, like the sperm count coming down by around 30%, mortality coming down by 23%, morphology abnormality increasing by around 51%. And further, there was a study in 2012 from All India Institute, which also showed a similar picture. What could be the reasons? Obviously, everything we attribute to the pollution, the lifestyle, everything, the air pollutions, volatile organic compounds, oxides of nitrogen, sulfur dioxide, and all those exhausts from the combustion engines. All these could be contributing, the chemical pollutants that we use as pesticides, insecticides, herbicides, and heavy metals that are there, which are coming as the toxins in our vegetables. And also it is mentioned that increase in obesity can also be a cause factor. Also excess heat. See, we know that the scrotum is positioned by nature in such a way that the core temperature of scrotum is around 1 to 2 degrees less than the core body temperature. So it is said that when the temperature of scrotum increases by 1 degree Celsius, the semen quality and quantity can come down by 15 to 20%. So increasing heat over the decades, which could be part of the changing dress habits in Indians, because our dressing habits have changed a lot, and that actually increased the scrotal region temperature. And also the habit of people to take hot bath, jacuzzis, and all these hot sauna and all those things. And also occupational exposure to machineries with high amount of heat. And also the dietary habits, like increased fat in diet. And also there has been increase in alcohol consumption, smoking, and also illicit drug usage like marijuana, which all these things, and also treatment modalities. A lot of diseases now have developed treatments which are a bit toxic to the germinal line, like alkylating agents and other drug therapies. So all these could have contributed as a whole towards a decreasing sperm quality. But finally, though said to be controversial, almost all the studies have uniformly pointed out that there has been a gradual decline in the semen quality and quantity over the last few decades.
Usha, a quick one. Do you believe in teleologic concept of medicine? Teleology. for what I'm trying to teleology. What I'm trying to get at is this nature's way of limiting the overpopulation on this planet, deteriorating sperm quality? I'm a quick one.
Quick answer is no. There are teleologic explanations for a lot of things, and I do believe in them, but not this one, because there are very tangible reasons that these things are happening, all very nicely elucidated by Joe and Dr. Sanyal, that those are all reasons that nature is not messing with. So if this was a decline that was happening organically, naturally, I would subscribe to that theory. But if we are doing these things on our own, like taking marijuana or drugs or things like that, I don't think it's nature.
Sir, can I add one point there, sir? Actually, about during that ECNA on endocrine disruptors, there was a sentence which mentioned that the amount of the spermicide that is present in one condom, if it is mixed in water, drinking water, it could actually make around 30,000 liters of water, of drinking water could be made to the toxin level that could induce infertility in fishes. Yeah, so that was there in the endocrine ECN.
Shubhankar, I'll just add one point that as Usha just is not in for of this, but it's definitely was shown that in a PCOS mother, the baby who is born, because of the excess of androgen level in the body, they are much more having the qualities of the male qualities, more aggressive in their studies and career. They, about the, morphology of those girls are much better, the more tall or having more hairy, but the behavior wise, they are more aggressive. They're better in mathematics. They want to, pursue career rather than going for dance and dresses and all those. So these are, reports that are coming up in the study reports. You cannot tell them very, significant or whatever. But as we can find that the girls as a whole nowadays coming out of this situation are much, much, different from that some 20, 25 years back.
Yeah, right. So now we try and get down into business proper, sort of. We had a lot of introduction to the issue. So we have now an infertile couple walking into a clinic, maybe a physician's clinic. How do we first decide who should be evaluated? Because in our male-dominated society, it's assumed, taken, that it is the female partner who is at fault and needs evaluation and treatment. So maybe first we look at the male part and then the female part. So Joe, would you quickly sort of tell us as to how do we decide or how do we evaluate, what history quickly should we take in the clinic itself?
Yes, sir. Here I have to talk about the practical scenario also. As you rightly pointed out, all infertility, unless proved otherwise, is said to be a female factor from the social perspective. So often when the couple comes for evaluation, usually the male partner is a bit more reluctant to get evaluated. So in the initial analysis, when we take the history, usually the way the attitude is that, see, we have been married for such and such years, we have been having regular intercourse, we have been trying for kids, and I feel that there is something abnormal, so why don't you evaluate her, is the way they approach us. So I think that approach has to be changed. But from the clinic perspective, when they come with that complaint, obviously I usually concentrate first on the female partner only. Just take the history from the female partner to see whether she is having a normal regular menstrual period. As my teacher told me, if the lady is having a normal regular menstrual period, it's very unlikely that she is having some abnormality. So if there is some abnormality like history to some features of PCOD, irregular periods, and all those things, I may be concentrating more on the female partner. But otherwise, if the female seems to be all okay, I always insist and make it a point to examine the male side also. I would say that rather than saying that, no, she looks fine, you may be the person at fault, I make it more sugary, saying that as a protocol, we always do both things together. Because again, that's from the social perspective. in those cases, that's the way we do it. And so we evaluate the people, the normal hormone profile also. And from the male perspective, I do ask him the question of any history of orchitis, any other history which would be contributing, the smoking, alcohol, stress, as you, sir, you said. See, commonly what we see is that stress is a major factor of oligospermia, and alcohol and smoking, which could be associated with stress also. So history is very important on these aspects. And then I do a basic clinical examination to see the pubic hair development, the secondary sexual characters, testicular volume, which would give me an idea. And often, surprisingly, I have found testicular volumes and clear-cut hypogonadism features when the male is totally reluctant to admit that he's having some problem. So when that happens, so again, I take both together, and after the basic evaluation done, so I would ask for both sides, and then the initial evaluation which I do for the male is FSH, LH, and testosterone, and along with that, I would do the thyroid function test and the general tests like CBC, LFT, creatinine, and all those things, routine examination. And the first and foremost thing after the clinical examination is to see from the clinical examination itself. Most of the time, I would be able to have a differential diagnosis of maybe it's a centrally placed or a primary gonadal failure, or neither of them. So from the baseline investigation of FSH, LH, and testosterone, I would be able to say whether it falls into which group. For example, if the patient is having a low testosterone with a high FSH and LH, I know that the testis is at fault. If the FSH, LH is low along with the testosterone that is low, I think that there is a central component of pituitary or hypothalamic lesion.
We will come to the investigations soon. So essentially, you do have an unbiased view. When a couple presents with infertility, it could be either partner, and then you also concentrate on the male partner. And then, of course, most of the time for female partner evaluation, maybe beyond the initial basic evaluation, of course, we also have to do. And then we have to leave it to Dr. Taboli Chakraborty to try and help us. Yes, Dr. What would you do?
What I do practically, I'll tell. So whenever the couple comes, many times the husband doesn't come. So when the couple comes, I always do the counseling, telling them to have a baby. You have to contribute chromosomes, half from your side, the genes and chromosomes, and half from your side, means husband and wife. So I have to see both. What is the situation of your egg and what is the situation of your sperm? So you please go to the right-hand side room. Sonography will be done where the volume of your ovary and antral follicle count will be made. And then you come out on the right-hand side, somebody is drawing blood. So you do an AMH blood sampling from there. We get report within 1.5 to 2 hours. In the meantime, the husband is asked to go to the semen collection room. You settle over there, collect your semen, give to my junior embryologist who will do this test and will give me the report within 1.5 hours. It is very important because once you tell the male partner, many of them at that point of time will not be able to give you the sperm. And the person who is sitting in front of you, smiling and looking at the wife as if they're having regular physical relationships, once this is done, many of them will come back and then they will reveal to you that we do not have because there is erectile dysfunction. We have andrologist and andrology department. So he now is being referred to that person who will do a real, as Dr. Judge was telling, physical exam, then sonography, maybe transrectal sonography, then TESA. Many of our, TESA gives very good result nowadays. Instead of going for the donor, we go for the testicular sperm aspiration and do an IVF, giving a very good result. So this boy is also very happy that in spite of the fact that I cannot perform, I am having a baby from my own sperms. So that was not known to them. So we reassured them and we go in this way. So the both of them simultaneously go for the tests and the reports come simultaneously to us. Now, no one to blame, but to help everybody at the same time. Psychological helping is the most important at that point of time.
Right. And what about pure gynecological cause of infertility when we evaluate for a tubal factor?
Yeah, so when we were doing our postgraduate, my subject was laparoscopy in infertile patients, and that was done in Medical College in Eden Hospital long back in 85, 86, and majority of the patients had tubal block due to tuberculosis. We find a few cases of endometriosis at that point of time, but now when we do it, majority have got tubal block due to some other factor, not tuberculosis. And routinely in endometriosis, the tubes are open. So tubal block, once we get and we cannot identify due to tuberculosis, then you have no other treatment than to go, you can do some hysteroscopic cannulation or laparoscopic cannulation. If it doesn't happen, then you have to go for IVF, and that's much easier, less costlier than any other methods available nowadays. If it is due to tuberculosis, you can prove, you give anti-tubercular treatment. And in endometriosis, nothing will help because tubes are open. Maybe the anatomy is distorted. Otherwise, a tube is not going to cause problem over there.
Right. So, but this must be news to, yes, Usha, I'll come to you. That IVF is not a costly procedure.
Less costly. I'm not telling not a costly. It's definitely costly, but less
Less than
costly than doing a laparoscopy, hysteroscopy, cannulation, then waiting for some time, nothing happening, going back to IVF. Because after doing cannulation, maybe 15 to 20% will conceive. The rest you again have to go for IVF.
Right. Yeah. Sorry, Usha.
So Shubhankar, I just wanted to kind of go to one basic stuff, which is like, what do we define infertility as? That it's a minimum of 1 year of unprotected sexual intercourse and enough number of frequency of sexual intercourse. So couples many times come to us when they have been married only for 3 or 4 months or 6 months because of family pressures. So that is one thing. And even then, many couples, they say as much as 40 to 50% don't get, healthy couples don't get pregnant in the first year, but normally get pregnant in the second year. So a lot of, the tincture of time and reassuring them is a very important step. And to your question about who should be investigated first, I personally think that because of the stigmatization and the way our social fabric is, it's a very good idea to definitely either do the male evaluation first, which is relatively simpler with the semen analysis, or definitely do it simultaneously, not the women first, because in about 35 to 40% of patients, the problem is with both. So if we identify a problem with the woman alone right away, she gets blamed and the man doesn't come for a checkup. So it's really important to do the men first, which is what I do in my practice, or do simultaneously.
Yeah. So Ratnamali has a setup whereby she evaluates both simultaneously. It's good. So we stay with you, Usha. So how do we evaluate for likely male factor infertility? What's the minimum basic that we need to do?
So I think Joe very nicely, explained it. History, physical, very important, is complete medical problems and their own sexual development, and then sexual history, a frequency of sexual intercourse, and all the smoking, alcohol, substance abuse, infections, STIs, very important. So get a good history, do a good physical exam, and we may be able to actually find a lot of the answers right then and there. Then after that, it becomes a very simple first semen analysis. If we have a perfectly normal semen analysis going by all the criteria, chances are there is no hormonal issue at all. Because unless all the hormones are normal, you don't get a perfectly normal semen analysis. So that's a very cost-effective approach also. But on the other hand, if we either get a low count or low motility or the morphology, then I think we should do, or a history of sexual dysfunction. We must do very basic testosterone. I do total first thing in the morning, fasting, along with LH and FSH. And if it's possible, you can add a prolactin and a TSH so that they don't have to keep coming back to the lab back and forth. But if you want to save money, you can do this basic and then add the prolactin and TSH if we want. So after this is done, then it will give us a pathway of, is the problem, if the FSH is high and the testosterone is low, we know that the problem is, like Joe said, it's in the testes. Then we have to get a karyotype. And why? And it's very important because we need to know about microdeletions and others, because sometimes there is a knee-jerk response. The count is low, go for ICSI, but not knowing what is the cause of the count being low. So it's very important to get a good, genetic assessment as well. So this would be the basic examination. But if we identify it as a low LHFSH or a normal LHFSH in the presence of a low testosterone, they'll have to get imaging of the sella and other workup of pituitary function. So in a stepwise fashion, I would do that. So this is a cost-effective approach to male infertility.
What about the instances of azoospermia with normal hormones? So essentially,
if the normal hormones are normal and azoospermia is there, then we'll have to look at possibly something, vas deferens absence or blockage or something like that. Occasionally, there's also retrograde ejaculation where you will also see things like low volume. So then we'll have to refer to an andrologist. We'll have to get a testicular biopsy because there may be maturation arrest in cases. And then you may have to do further investigations to see if the vas deferens blockage is there, and some surgical procedures can be done, or retrieval of sperms from the testes itself. So we'll have to go to an andrologist, which is the next step for testicular biopsy.
Right. So, Dr. Dimalo, Usha has correctly pointed out that semen analysis possibly is the most cost-effective initial evaluation for male factor infertility. So, how do we interpret a semen analysis? So what would be the criteria of passing that as normal and abnormal? I know the values are going on changing. WHO defined normal values are changing. So quickly, practically for the busy physician, what are the figures to look at?
Yes, as we have discussed, a very good history is important, pubertal development, and then examination is very important. Most important is not to forget the testicular volume. That's very important, as well as development. And then going for probably the first line of investigation with regards to male infertility is always a semen analysis. Then we don't need to go for the costly hormonal analysis as well. So with regards to the World Health Organization's last update, that is in 2010, the values have been constantly decreasing. So very important is though we say at least most of us would require, we would like to go for at least 2 samples, but generally if the first sample is okay, we don't go for a repeat sample. But if you go for a repeat sample, it has to be done after about 1 month's time. Ideally, one should have a 2 to 7 days of abstinence. That would be ideal. At least 3 to 5 days would also be acceptable. And what is important is, though it was, we have previous papers suggesting a 4 ml volume is necessary, but now the criteria is about 1.5 ml. Anything more than 1.5 ml is normal. Basically, this data is derived from the 5th percentile of all those couples who have managed to achieve fertility within 12 months. So it is the 5th percentile data. So, it is the lowest level which can give rise to normal conception. So a volume of 1.5 ml is supposed to be adequate. Again, sperm, the total sperm count is around 39 million. Previously, even if we used to see in India also 30 years back, the average sperm count was about 60 million, but now the WHO cutoff is 39 million in terms of total sperm count. With regards to concentration, it's about 15 million ml of ejaculate. This is very important again, because, in terms of deciding which, if there is infertility, which treatment modality, whether we will go for IUI or ICSI, this is also very important. With regards to more, sometimes we don't have significant abnormalities in sperm count, but also there is abnormality. We need to look at the abnormality in motility. So at least 40% total motility, that is progressive and non-progressive motility, is necessary. With progressive motility, at least more than 32%. Then there are several categories of motility with regards to class 1 and class A and B motility. At least 50% of the sperm should be motile, and if they are absolutely non-progressive and non-motile, then one should look at vitality as well, because at least 50% of them should be, sperm should be surviving. We have to go for a separate staining as well. With regards to morphology, previously there has been suggestion that for adequate fertility purposes, we require at least 14 to 15% of normal forms. But with regards to recent Kruger guidelines and the World Health Organization criteria, 4% seems to be a normal, is adequate enough for pregnancy as well. But what is very important is we should not look at only one parameter per se, because even with one single parameter, the odds of infertility rises by about twofold. But if we look at the different parameters, that is the count, the motility, the morphology, and all of them taken together, the more number of abnormalities we have, the higher is the chance of having a problem with regards to fertility as well. So it's all the parameters which have to be taken into account. So with motility, we may have azoospermia, we may have, if there is azoospermia, and also we can have also oligospermia as well. With regards to motility, we can have asthenospermia. With regards, so these are the factors which we need to concentrate on. And after, if we have abnormalities in the semen analysis, we go for the testosterone, LH, FSH, regard deciphering which is primary hypogonadism and which is secondary hypogonadism. Again, we need to differentiate between obstructive and non-obstructive azoospermia. This is very important. If there is testicular volume is normal with a normal hormonal profile, probably we are dealing with a non-obstructive, with an obstructive azoospermia, and there the outcomes, especially with regards to andrological procedures, can be good. Whereas if there is a non-obstructive azoospermia with a raised FSH level, then that can be something's primary testicular failure. Then it's a different ballgame. We have to go for genetic analysis, including karyotype, and looking for Y chromosome microdeletion. And these are more common in Indian population, especially the Y chromosome microdeletion is more common in our population.
Right. So, sorry? Yeah.
Shubhankar, can I add one more point?
Yes.
See, for this, as Dr. Shannon was telling, that we have now compromising with a lesser motility at WHO guideline 2010. If we get lesser motility, we nowadays go for a DNA fragmentation test. And earlier it was more than 15% DNA being fragmented. If you can find, it's a problem situation. Nowadays it has gone up to 30%. So if we, majority of these not oligospermias, but asthenospermias, when we find that there are DNA fragmentation problems, these can be treated medically, though have to be given for a long period of time. And also we are doing karyotyping regularly in cases of morphological problems. And we find a lot of variations. We have got a genetic counseling department where they are being sent. Problem in the 9th chromosome, that gives rise to the morphological problem. The problem in the 11th chromosome, that gives us, so we do not know all of them, but in the geneticists they know, and they can very easily predict, no, you don't go for ICSI with this sperm. It will cause another problematic situation. There will be no implantation, or there will be early abortion, so don't go for it. It becomes easy now to counsel the couple that please go for donor. But nowadays we are, as Dr. Shanal was telling, if it is obstructive, fair enough. KESA gives very good result.
Right. So we already have a few questions in the chat box. Dr. Agarwal says there are many home-based semen analyzers available in USA. Do we have similar approved analyzer in India? Any advantage of such devices?
No, we are not using anything like that. And probably if it is in US, it will come very soon over here. But the point is, Shubhankar, I'll tell you my experience some 7 days back. Husband and wife, both of them are advocates, and they are not having any relation physically for last 5 years, since marriage, in fact. Came for an IVF baby with donors. Husband's sperm, as told by him, is okay. Anyway, we asked to collect the sperm, and he went off giving us the sample, which was found to be a liquid soap from the toilet for the first time. And if you say that, then you are in a soup. Again, we called, we have messed up with the testing, so please give another sample. So he said, can I bring it from home? Yes. So he brought it from home, gave us, and that is a good sample. I don't know whether it is his or somebody else's, but he provided like that. So home sample might land up in this situation if it comes over in India, because Indian males are very, very prejudiced about him having, some problem for fertility.
Don't be prejudiced against Indian males.
I'm not so, but really, if somebody can give some liquid soap for, filling up.
I understand. This is the first time I heard anything like
I
that.
have also saw it first time when it was put under microscope. We could see it.
Right. So we all are.
Actually, I also agree with Madam, because see, in our part also, the males are really trouble making. So that's why in my clinic, clinical examination can be done in 10 minutes. Hormonal evaluation, I get the results in 1.5 hours. And the semen analysis is a very big difficulty. So that's why I always keep it as a second line investigation in our practice, because it's difficult to get it from me in the initial part.
Right. So we all agree that for male infertility evaluation, the first step is semen analysis. And we have understood from Dr. Debbanju Sharma the different abnormalities that you can get. But what do you do understanding those infertility? Those abnormalities. Do you just say, throw up your hands, so you got a bad semen, so you can't have a baby? Do we have any treatment? Let's say for asthenozoospermia with average reasonable counts. Do we have anything to offer? First, Joe?
So I think we have to, see, from the endocrine perspective, when we have a low count, I always go for a clinical.
We talking of the low motility, let us say. Asthenozoospermia count is reasonably okay. And for that you have as help Dr. Akash. He suggested any role for antioxidant therapy, any role for zinc tablets.
See, sir, these antioxidants and zincs are routinely prescribed, but from the theoretical perspective and from the scientific evidence perspective, the evidence is very low in this aspect. So I'm not very sure whether scientifically we should be advocating usage of them. But we commonly see that being prescribed, but the scientific evidence is very low. And from the other treatment aspects, what we can offer is one thing is commonly seen is that control of thyroid function and diabetes. Diabetes control and other metabolic parameters control can do a good. And usually when the hormone, other parameters are there, I usually wash my hands and send it to an infertility specialist.
Right. Shubhankar, I also want to say that a lot of people try things like zinc and euhimbin and low dose clomiphene and giving testosterone, and then rebound after giving test. All of that, I think that there's no evidence to say it works. The only thing is with varicocele ligation. Even that is doubtful. The count improves. Does it change the actual live baby rates? Not sure, but at least definitely the count improves. That's the only place. So I personally, do not recommend any of this mumbo jumbo to any of them, and I think it saves them a lot of heartache and over a period of time. And I think the subsequent questions on adoption and all that is critically important in this line. But definitely, I don't think these other things work.
I agree with that.
One point, sir.
Yes.
I see all these drugs work on that one point which you initially mentioned, stress factor. See, the ladies, by the time they come to us, they are put in a lot of stress. So when you give some medicines, placebo kind of tablets, the zinc and antioxidants and all those things, and ask them to relax, have a good try for the next time, this will be the drug, you don't have much of a problem. That actually reduces the stress level, and that itself can do some benefit. That's what I feel.
Yeah, exactly. I mean, that's what I was trying to say. I mean, despite trials not having come out positive, giving something can sometimes help. I mean, it may not be scientifically proven. I mean, that would be the use. But on the context of oligospermia, so I still do use clomiphene citrate, but I understand it is not actually approved for use. So, Joe, would you like to quickly comment on that?
So personally, I haven't used clomiphene, so I won't be able to.
Usha also doesn't use. So, Debalo?
So, sir, I haven't used clomiphene with regards to oligospermia. I haven't used that.
Right. Ratnamali,
we used it some 17, 18 years back, not now.
Right.
When there was no other therapies, it was being used 25 milligram of clomiphene citrate, not now.
Right. Yeah, sure. Okay. So maybe now we sort of for the investigation of the female partner, Ratnavali, do you have anything more to add, or we are sort of done as to how to evaluate?
Lot of things that can be done to evaluate. I think is obvious gathering is not waiting for that. What I would like to say today, we have managed polycystic ovarian syndrome cases. It's a vast majority of anovulatory infertility. We are not scared of that. We know how to deal it, and ultimately that's not a problem to treat their infertility. But now the problem is lying in two cases. One is endometriosis, which is a day by day it is becoming rampant, and it's very difficult to treat, and loss of fertility in case of female. And one is premature ovarian insufficiency. So these two are now locking into the situation, and these are causing a big headache to us, because till today, if it is a premature ovarian insufficiency, you have to treat nothing else than by donated oocytes. And maybe in future stem cells will come into play, but till date, nothing is there. And for endometriosis, it is really, really difficult situation. If we start talking, it will take next 1 hour. So I'm not going into the details, but we should keep in mind that many places where, the first tier 1 infertility treatment is being done, people usually go for tubal, patency tests, and it is found it is open, and people are very happy. Go and try yourself. Many of them will have mild or minimal endometriosis. Moderate you can see in a sonography, but mild or minimal you cannot see. So don't tell them that you go and try for next 1 year and then come back. By that time, she will lose the rest of her eggs. So this is one point I wanted to say. And one is
So is this endometriosis of the ovaries, or is it of the uterus?
Not uterus. Adenomyotic uterus, they can conceive and they can continue, though there will be problem during a cesarean section. But otherwise, conceiving is not a big problem unless it is very much, distorted. Right. But endometriosis, even the mild one, that causes a very, very big problem. Why I'm not going into details.
So where is the endometriosis is what I'm trying to find out. Is it
in the ovaries, in the peritoneum, on the wall of the uterus, but not adenomyosis. Adenomysis is when the endometriotic legs are present within within the muscle myometrium and distorting it. Then that's not a big issue of getting conceiving. But when it is on the ovaries, either they are causing endometrioma or not, doesn't matter. But mere their presence on the ovaries or on the peritoneal surface, that causes infertility in the woman. And another is unexplained infertility, when you are not finding anything. Maybe the cause we have not discovered till date, but many physicians or gynecologists will say, you just go, there is nothing, so you do not worry. But this is the point, that when you cannot find a cause, you have to go for assisted reproductive technologies. Otherwise, if you say the time will pass, maybe 1 out of 100 will conceive, but 99 will gradually lose the number of oocytes in their ovaries, and they will ultimately, when they will come, donor oocytes will be the only answer. So these 2 points I wanted to say: endometriosis and unexplained infertility. You have to deal it very cautiously and with guarded opinion, not like before.
At this point, we do not have any effective medical treatment for endometriosis.
See, Shumankar, you know better than me. There are a lot of treatments, which means there is no effective treatment.
Yeah, that's
and you do surgery, you have missed the bus, which means you have destroyed a lot of oocytes from the ovarian cortex. So it is not recommended until it is absolutely necessary before treatment for the IVF or whatever. So, if it is not absolutely necessary, we don't go because of the pain, because it is 8 centimeters in diameter, very big, or it will be difficult to retrieve eggs from during doing IVF. In these cases, we do a prior surgery or GnRH therapy. Otherwise, for any other reason, there is no reason to wait and treat medically or surgically before going for IVF treatment.
We have already crossed our time, but we'll quickly try and wind up. So can we have Dr. Debanga Sandal sort of trying and putting together what could be possible medical treatment for male infertility? Maybe let's say secondary hypogonadism. How can we help the male?
So with regards to secondary hypogonadism, sir, it's one area probably where we have quite a satisfactory outcome, especially from our endocrine perspective. We have a lot of patients having hypogonadotrophic hypogonadism, which is idiopathic, and also with regards to some other pituitary causes like tumors. And once they have resolved, especially with regards to if there is a tumor, if there is no tumor recurrence, then we can actually, after correcting the other hormonal abnormalities like thyroid function and cortisol, then we can actually have a good outcome, especially with regards to secondary hypogonadism. Gonadotropin therapy is the primary treatment which we can offer with good outcome, especially if there is a reasonable amount of testicular volume, especially in post-pubertal gonadotropin deficiency. In a lot of patients, we can actually do with an HCG alone, and in some definitely we would require about more than 50% we would require HCG plus FSH. It's quite a simple regime, but again we need to give time for at least 6 months to titrate the dose, have an optimum testosterone level, and then look for the semen analysis if there is adequate sperm concentration. If there is still inadequate sperm concentration, and where we need to add an FSH also 3 times weekly. And by the time of by about a year's time, a lot of our patients have significant improvement. We have had significant patients. We had quite a number of patients having even improvement at 3 to 6 months time as well, only with HCG treatment. There, the baseline testicular volume is very important. If the total testicular volume is more than 8 cc, or the testicular volume individually is more than 4 cc, then the outcomes are much better, which we have also published as well. Whereas if it is on the lower side, the outcomes in most patients, they would require an FSH as well with regards to optimum outcome. But still, in spite of that, there are a few patients which we have seen, about 10 to 15% of patients, even with the secondary hypogonadism, where there is failure with regards to both FSH as well as HCG as well, then probably suggesting some amount of intratesticular defect as well. Probably in those scenarios, a GnRH therapy has been suggested by some that they may be better, but that is much more expensive, requires pump, and we haven't had much experience with regards to GnRH therapy. And with regards to primary hypogonadism, of course, we have seen there is not much of a significant role of any gonadotropin therapy. With regards to obstructive azoospermia, obviously, the sperm extraction, especially from the epididymis, may help in a lot of our patients. And especially in Klinefelter syndrome nowadays, which we also can, we are doing microtesy as well, which is has been found to be beneficial, especially in the testicular sperm extraction, where in especially Klein with primary hypogonadism, in some of the patients, it can be effective if it is done at an early period or an early stage. But with regards to hypogonadism, secondary hypogonadism, in most patients, the treatment is quite satisfactory, especially if we have, if we wait and give adequate time, and combination of FSH and HCG can go a long way in terms of improving the fertility outcome in most of these patients.
Yeah, and you already mentioned that we need to explain to them that it is a lengthy process. It will be several months before you see significant improvement. So there would still be individuals, maybe primary hypogonadism, gonadal failure, where you have azoospermia, and where that leads us to maybe the scope of a sperm bank. Joe, would you like to talk a little bit about that? Yes.
Sperm banking is something that is not really taken care of often. I feel nowadays the newer generation and with the new advent of Googling, even patients are becoming more aware of the sperm banking, and some patients do come up with the question, and most of the time we are not the people who face with it, because most of the time what I feel is the sperm banking as a requirement is coming with the anti-cancer therapy, because a lot the malignancy incidence is going up very high, even in young population who haven't completed their family. And for them, when it all depends on the treatment that is getting offered. So it's primarily for the oncologist to plan. Once they plan the treatment, they have to see whether it can affect the fertility. And in case if it is going to affect the fertility, it is mandatory that they discuss with the patient of the risk that is involved, and then suggest to them about banking their sperm or the ovum, so that future fertility can be utilized. And again, the problem there is that how to go about, where to bank it, what is the cost involved, all these things the oncologists are not really clearly aware, and often they miss this part of the treatment aspect, and finally the patient gets cured of the disease but has a lot of psychological aspects remaining when they think of building up a family for themselves. Another big area where even endocrinologists fail to actually concentrate is in the transgender patients. Recently, I had around 6 months back in Kerala, a transgender couple, a transgender male and a transgender female, actually committed suicide. The reason being they actually wanted to go and sue the doctor and all those things, because they were saying that they were not clearly informed of preserving their gonads initially in banking so that they could have a future kid. See, when I directly asked the doctor who was involved with the case, then what they said was that, see, at that time, the only thing that they wanted was a gender transformation, and the cost was a real concern. They had just mentioned about it, and at that point, they were not at all thinking about fertility. They just wanted a change of gender. But after that, once they changed the gender, things changed for them. They went to a group of transgenders. They fell in love with each other. They married, and then they wanted kid. And once they started having that, then all the problems started. So even in transgender surgeries, transgender persons, it's an important concept and thing that we have to discuss. And as endocrinologists, we should make it a point to discuss a possible fertility that can come up in the future. Even if they change their gender, they can still have kids if they preserve the gonads initially. Another part is now with the early diagnosis that is happening, Klinefelter syndrome sometimes come up to us with the fertility that can be there. A few sperms may be remaining at that point of time when the patient is initially diagnosed. Not like the time when I was doing DML, we never used to see that. Nowadays, we do get a diagnosis early of Klinefelter. At that time, if you really, but again, the problem there is that I have had recently also, I had a kid was diagnosed at 13 years. I could diagnose him from the features that it was a Klinefelter, which was karyotype proven. I suggested them of preserving it, but the parents were not really convinced. They were saying that, see, doctor, if it is there, then why are you doing it now? How can you take it out and preserve it? We are doing such a bad thing for the kids. So it becomes a lengthy process of convincing them also. And the sad part was that they went to a second opinion, and I lost the patient, but I got the follow-up from another person saying that they left you because you insisted on preserving the sperm, and another doctor said that that's okay, we'll see when it happens.
Right. So coming from sperm bank, can we have a few words about ovum bank? That's more in use, possibly, Dr. Ratnavali.
Yes, as you are talking about the oocyte banking, when you thaw it, the result is far less than we do on embryo banking. So embryo banking is more popular, cryopreservation of the embryo. So we get a lot of patients when they get pregnant now, there are leftover embryos, they say you cryopreserve, comes back after 2 years and again gets pregnant with that. So embryo banking, I think it will improve day by day. But what is really important is oocyte banking. Now with the method that we are possible in Calcutta, I don't know in other places, the result is not as encouraging as in the embryo banking. So we are getting girls, as Dr. George was telling, after before going for a chemotherapy or a radiotherapy or surgery, if we wish to bank it, nowadays from Tata Medical Center, they are also coming to us, approaching us to keep the ovum, means from the ovary, you tissues and bank it. It's not very popular till date, but we are trying to do it in a better way. But embryo banking has come a long way. For example, we got a couple, and they are not married, and the mother-in-law of the girl came and told that they are now staying abroad, one in America, one in UK. So I would like the embryo to be made and frozen till they have a social marriage, maybe at the age of 35, and when you can, embryo transfer the embryo back. So things like that are coming up. Young girls are coming, single mothers are coming, but oocyte banking in Calcutta, I don't know about what happens in the southern part of the country. Not as encouraging as embryo, but we are trying hard, maybe another year or so. So with the Tata Memorial Center, Cancer Center, we are working so that we can help them up. Yes.
No, so that's one side, but the lady who has had a premature ovarian insufficiency.
Yes, definitely. Yeah.
Not look for a banked oocyte for fertility.
Yeah. So the oocyte of the same person or from a donor?
From a donor oocyte.
Yeah. So donor oocytes we get regularly. Okay. And recently, you have seen from ICMR and from Government of India Health Department, there are some rulings came, which will be from 1st July, they will be, in place. And here it is said that all old rules and regulations have been removed. And from now, one donor can, donate for 2 times. And there can be only 2 pregnancies. Earlier, we used to make embryos and divide them. Sharing, we used to say them. So all these sort of things are now changed. So now new regulations, we'll have to find out what we are going to do, because the donor program is a very big problem nowadays because of endometriosis, premature ovarian failure, so on and so forth, coming at late age, as we were discussing. So donor site is a big program now, but what will happen after July, that is a point of so many donors. You have to find individual donors from those background every day, which is very difficult. Nowadays, the agencies, they bring donors who are repeatedly, many say 3 to 6 times they are allowed to do, but there should be a gap of 6 months. So that will not be possible now.
Right. So I think we need to soon bring this to a close. Wonderful discussions from all across. So there's a question from Dr. Pradeep. What ethical issues we need to address before recommending someone to donate sperm for future use, whether it's for the same person, probably. So the ethical issues in sperm bank sperm. Dr. George, would you like to comment?
Question is not very clear.
Yes, sir. The legal aspects and things, I am not very sure of the donor sperm and all those things. Legal aspects, I am not very sure, sir. Because
no, but they also, yeah, this time with the ovum donation, also sperm donation rules have come. Previously, you can any boy or any man can donate sperms as many times as he wanted, but now probably 6 or something like that has come up. And they are under, again, they have gone for amendments. So once it comes up in July, we'll clearly know. And of course, it is anonymous, it is altruistic, so you cannot pay. And definitely all the screening tests had to be done, including all the infections, the hemoglobin electrophoresis for thalassemia carrier state, and everything has to be seen. And then only that we are doing till now also. But the number of donations that have decreased. You cannot go on for any number of times.
Good. So I think the message that we got from our faculty this evening is that infertility is also on the rise. Various reasons, social, economic, environmental, and so on. But at the same time, I think the silver lining is our evaluation is getting better. Our treatment is also getting better, as Dr. Chakraborty also emphasized. IVF is there, ICSI is there, and facilities are now being available at more number of centers. Hopefully, cost for these will also come down and will be available to more number of people. So, and then of course there are issues like beyond what's provided in these clinics, the issue of adoption, and those are also further issues that need to be considered in the overall consideration of managing infertility. So I would like to thank very sincerely all the panelists this evening, Dr. Usha Sriram, Dr. Digmal Sannal, Dr. Joe George, Dr. Ratnavali Chakraborty, and of course, I do hope Dr. Varghese Iyer, whatever family, medical emergency in the family, this has been sorted out or will be sorted out soon. I'll find out from him later. So with these few words, I'd like to thank Pintas once again for being with us for last several months, and over now to the organizers for the final comments.
Yeah, very good evening, doctors, and thank you for a great session. Today, again, we had an intriguing session on a very relevant topic from the experts in the field of endocrinology and gynecology. I'm sure the audience would have derived great learnings out of this, and we could have addressed a lot of the queries being in the mind of all the participants. On behalf of Intas Pharmaceutical, I'm individually thankful to Dr. Usha Sriram, Dr. Ratnavali Chakraborty, Dr. Digmal Sannal, Dr. Joe George for the rich insight you have provided during the session, the engaging deliberation, and also, dissecting the topic. We can look at the topic from various aspects as well. So thanks a lot, doctor, for that. More importantly, we are ever indebted to Dr. Shubhankar Chaudhary for his effective moderation, help being a mentor for the program. Last 1.5 years, we have been running this ever successfully with a large number of participants, just keeping on adding. That's because doctor has been able to bring in every time, some challenging topic and keeping the audiences hooked upon. So thanks a lot, doctor, for the same. Finally, I would like to thank all the audience. Today, we had 972 doctors attending the session. So this has just kept on increasing with every session going by. Thanks a lot for spending the weekend with us. I'm sure all of you would have got great clinical value applications in through this program. Wishing you a great weekend. Have a good night. Thank you, doctors. Thanks
Thank you
again.
very much.
Thank you, sir.
Thank you.
Thank you.
Good night.
Thank you. Good
Namaskar.
night. Good night, ma'am.
Good
Thank
night.
you. Thank you once again.
Thank you, ma'am.
Thank you,
Good night,
sir.
sir.
Thank you, sir.